Rubinstein. Dr. Rubinstein is a pain specialist and a researcher at Kaiser Santa Rosa, and her main job is undoing patient by patient some of the damage that's been done by high-dose opioids, and she's really turned the lives of people around remarkably. Dr. Corey Waller is an emergency room doc, an addiction and a pain specialist, and has worked with California Healthcare Foundation on working with complex patients. And we brought them both up today to talk about, well, how do you make this work in practice? Working with individuals with chronic pain or addiction, how do you talk with them, whether you're a doctor or a friend or a family member, to really help them realize life could be better? And so we're going to have a fun session. We're going to do some role plays. We're going to have some Q&A, but we're going to start off with short presentations by each of them. So, Dr. Rubinstein.
Hi. Thank you. It's a real honor to be here today. And thank you, Kelly, for inviting me and bringing together so many great minds to talk about such an important topic. As she said, I am a boots-on-the-ground pain physician, but I'm also an anesthesiologist, and I think my training and background in anesthesia really informs the way I look at this problem. Are there any anesthesiologists here today? They're usually in the back, playing Sudoku. Oh, I'm all by myself. Okay. Well, what we do in anesthesia is kind of shrouded in mystery, and truth be told, we kind of like it that way. But at the root of who we are pharmacophysiologists. We use pharmacology to alter physiology in really one of the most extreme ways you can imagine. General anesthesia is a pretty extreme alteration of your physiology. And so as a result, we don't look at drugs as good or bad or dangerous or not dangerous. We just see them as molecules that can be used in certain situations. I think we can all agree that propofol, a drug probably everybody's heard of, is not a good idea for home administration. But you really wouldn't want to have a general anesthetic without it. So it's all about looking at how a drug interacts with your physiology. So I thought in the next 15 minutes, I would try to make everybody in this room an anesthesiologist. And 15 minutes is more than enough time. Trust me. We're incredibly simple people. And we like rules. So I'm going to share with you some of my rules of anesthesia as a lens to look at opiates. Okay, so rules of anesthesia, rule number 1. Don't let the patient die. And that's funny, right? Except that if you think about it, every single general anesthetic that you give is a lethal injection. Same drugs, exact same drugs, minus the potassium. But we don't let the patient die. So we take that one really seriously. And right behind rule number 1 comes rule number 2, try not to let the patient suffer. We take this one really seriously, and that's actually why pain medicine is an outgrowth and subspecialty of anesthesia. But here's the thing. You never look at rule 2 until you've figured out rule 1. And I think if all of us as prescribers had done this with opiates, we probably wouldn't be sitting here today talking about this. Because we really did want to help our patients. They were suffering and we wanted to help. We tried to cure their suffering, but we forgot the part about not letting the patient die. And so we need to fix that, and that's what I'm going to talk about. Now, the other thing about anesthesiologists you kind of need to know is that we love history. And not necessarily American history or world history. What we love is what happened yesterday. Hey, Joe, how did that case go? What happened in the OR yesterday afternoon? Or let me tell you what happened to me on call last night. Because we don't want to make the same mistake twice, and we want to learn from the mistakes of others. And thankfully with opiates, we have a really long history to draw on because it swings like a pendulum. And it's been swinging back and forth since the time of the pharaohs. And we don't have to look back very far to see a complete cycle. In 1898, Bayer Pharmaceuticals released heroin to the US market as a treatment for menstrual cramps and other female afflictions. And that seems outrageous to us today. But I'll tell you, in the last 30 days, I have seen a new patient who sent to me on OxyContin for menstrual cramps. So I don't think we're learning from the mistakes of others, and we're making the same mistake twice, and we need to stop that. The second piece of this really is we got to own this one. Because here we are now in 2016, the cycle came up. We had very conservative opiate prescribing through the first part of the 20th century. I agree 100% with Dr. Kolodny. 1996 was really the pivot point. I'd like to say that I graduated medical school in 1996. And now we find ourselves in what's been called an opiate epidemic. And it may just be semantics, but I don't like that term. Because an epidemic makes this sound like this is something our patients are out there catching. And who's the hero in an epidemic? We are. We treat epidemics and we fight epidemics and we halt the tide. But we caused this, and we got to own it. Now, as I said, I graduated in 1996, and I trained in anesthesia with the idea that you could prescribe opiates long-term safely and effectively. As long as you monitored for constipation and respiratory depression, everything was good. And I don't think there's a single mistake in opiate prescribing that I haven't personally made. But I've learned from my mistakes, and I'm trying not to make the same mistake again. So this first step, if you want to fix a problem, is admitting it. And so this isn't an epidemic, this is an iatrogenic mess, and we got to own it. We got to own it. But what's actually happening out there? 70% of physicians blame their patients for their problems with opiate use. Now, in the middle of a problem, blame's not that useful. But if we were going to hand out blame, there's a lot of people in line ahead of our patients for how this happened. This is not our patients' fault. They came to us in pain, and they were suffering, and we said we could help, and we put them on a drug we didn't understand, and the most important thing, we didn't know how to stop. And the reason people are on opiates long term, I think most people in their practice know that they're not working, but we don't know how to stop them. Now, this is another rule in anesthesia, and I'll tell you by way of a joke. A guy gets a bill after surgery from his anesthesiologist, and he calls the anesthesiologist up, and he's furious, and he says, "I cannot believe you charged me this much money to put me to sleep." And the anesthesiologist says, "Sir, I put you to sleep for free. That's the bill for waking you up." See, it doesn't count if you can't wake them up. You got to be able to wake them up. And you got to be able to stop a drug that you start. And so that's what we're going to talk about here. So what is a taper? It is a progressive decrease in the amount of opiate taken with the goal, and this is important, of leading to reduced risk and/or greater overall quality of life for the patient, not for you. This is not designed to make your life better. This is about making the patient better. And when do we taper? Well, we taper when, it's really simple, when what the drug is doing to the patient is more than what the drug is doing for the patient. We don't taper patients to punish them. We don't taper them because we're not comfortable. We don't taper them because they've reached some arbitrary dose. We taper them to make them better. And if we keep that in mind and we keep a pharmacophysiologic approach to this, we look at their physiology and we look at what's going on and we look at what their benefit is. It's kind of like saying risk-benefit, except the problem is that the word risk has been a little bit hijacked at this time to just mean addiction, abuse, diversion. There's a lot more risk than that. So, how do you figure out the risk? Well, this is how I do it. I hope you can see on this slide. The left column is all of the addiction, abuse, and diversion. And those are problems to be sure, and we've heard a lot about it, and I'm sure we'll hear more. But you can have a patient on a very low dose of opiate. You can have a patient who's got their opiate agreement and their urine toxicology is fine and their cures report looks great, and we can still be harming this patient. We can have a patient that looks like this, that has these risks. So the problem with a focus that's overly narrow on addiction is that we're missing the medical risks. And this afternoon, I'm going to go into these in detail, and we're going to do some cases on how to actually look at patients and see who's at risk, who has sleep apnea. Did you know 70% of all patients on opiates have sleep apnea that requires treatment? Or 75% of men don't make enough testosterone to maintain normal bone density. These are things that are part of knowing these drugs and what they do. Okay, so where the rubber meets the road, how do you really do this? And for a long time, there was nothing in the literature about it. Now there's a couple of papers on how to taper patients, and they talk about this percentage drop and that percentage drop over this period of time. But the most important thing, if you're going to taper a patient down effectively, is you got to get buy-in. Anesthesiologists are great at this because we sell patients on all kinds of crazy stuff. We say, sir, I'd like to tip you on your head and stick a giant IV in your jugular vein and then pass a long catheter down through your heart and out into your lung, and then I'm going to blow up a balloon. And they go, okay. Okay, that sounds good. You know why? Because they really believe we're doing it to keep them safe and make them better. And as long as patients know that, they'll agree to just about anything. What they don't agree to is, I have to do this. The government says, I say, my boss says. They know that. You gotta put the patient first, and you gotta get buy-in, or they'll subvert you, and they'll go to the guy down the hall or down the street or across town, or the guy waiting on the corner with heroin. You need to maintain their function. And this is really important when you're tapering in an outpatient setting. These people have jobs and lives and family. And if you taper them at a rate that their physiology can't tolerate, they're going to lose their function. And if they lose their job, they lose their insurance, they're not taking care of their family, they lose their home because they're at home with diarrhea because you're tapering them too fast. You haven't made the patient better. So you need to respect their physiology. And anybody in here who's ever had a patient on long-term steroids, prednisone, anybody taper long-term prednisone patients? Okay. You know that how fast can you go? You can go as fast as the patient can go. You can't go any faster than that. Function is really important. 0 is not the goal. And you've heard it said today that some people's brain chemistry is changed from long-term opiate use. It's sad, especially if they got put on it for a reason that really was not particularly valid, and now they're on it. But some patients won't get to 0. And 0 is not the goal. The goal, right, is to make the patient better. Wherever that is, that's okay. And drugs like buprenorphine can be really helpful in this. But there can't be an arbitrary goal. So you need to reassess them often. And the best place for this patient is with you. And you gotta believe that. If you lose your therapeutic relationship with this patient over an opiate taper, you've lost not only the ability to taper their opiates, and believe me, there's lots of people out there who are gonna be more than happy to hand out opiates to patients, but you've lost the ability to manage their diabetes, their blood pressure, take care of their kids if you're a family doctor and you see entire families. It's not a good trade-off in most situations. Now, there are exceptions to this, obviously, but overwhelmingly, you want to make sure that this is a partnership. And I taper probably 95% of every patient that's sent to me, and 40% of them, if you just say, would you like to take less opiate? If we could do it in a way that would maintain your function and your pain probably wouldn't get any worse, 40% of them right out of the gate will say yes. There's a study on that. And some take a little more convincing, but you gotta be the salesman, right? Now the last thing I wanna say is rule number 3. I kind of skipped over rule number 3, right? Rule number 1 is don't let the patient die. And rule number 2, try not to let the patient suffer. Rule number 3 is keep everyone else in the room happy. And this means playing the music the surgeon likes, even if it's Metallica at like decibels that make me want to pull my hair out. It's keeping everybody mellow and happy in the OR. And all of us have people in the room. We have our patients' families. They can put pressure on us. Our colleagues, our groups, insurance providers. And it's okay to try to keep them happy. But remember that piece, those metrics that you're being asked to achieve, that's rule number 3. And when do we do rule number 3? When rule number 1 and rule number 2 are under control. There's no music in the OR when the patient's dying. That goes off, right? You need to make sure the patient is doing well and is safe and they're not suffering. And then feel free to make everybody else in the room happy. And I think the last thing I want to just leave you with is, as this pendulum swings on opiates, we're the people who should be driving this. This should not be being driven by big pharma, driving it in one direction, or by politics or law enforcement, driving it in the other. This is a physiologic problem, and we are the people most suited to be the leaders on this. And we are the people who should be driving how these drugs are used, in what situation they're used, and who uses them and for how long. Drugs aren't good or bad. It's all about context.